You are listening to the Horse Radio Network, part of the Equine Network family.
Welcome to this episode of the Daily Vet Life podcast, where we chat with equine veterinarians about the cases they've worked on in their clinics. I'm your host, Alex Beckstedt, Editorial Director of Equimanagement, and today I'm speaking with Dr. Kelly Knickelbein about one of her ophthalmology cases. This episode of the Daily Vet Life podcast is brought to you by DECRA. Dr. Knickelbein is a 2015 graduate of the University of Pennsylvania School of Veterinary Medicine. She completed an internship in equine medicine and surgery at Rhinebeck Equine and a comparative ophthalmology internship at the University of California, Davis. Following this, she stayed at UC Davis to complete a residency in comparative ophthalmology. Dr. Knickelbein is a diplomat of the American College of Veterinary Ophthalmologists and has been working at Cornell University since 2021. Her clinical interests include all aspects of equine ophthalmology, and her research interests include heritable ocular disorders in horses and the application of advanced ophthalmic imaging techniques in large animals. Thank you, Dr. Knickelbein, for joining us today.
Yeah, thank you so much for having me.
So let's jump right in. Go ahead and tell us a little bit about the case that you'll be sharing with us today and how the horse first presented to you and your team there at Cornell.
Absolutely. So I'm going to talk about a 4-week-old Morgan colt who was born with an advanced cataract in one of his eyes. In this case, the cataract was known to be congenital, as it was identified soon after he was born by the owner and then confirmed to be present on his new full exam. The colt was otherwise healthy. He was well-bred, intended to be developed as a show horse. And so soon after the problem was identified, the owner, kind of in collaboration with their primary veterinarian, reached out to us to see about options for cataract surgery, which is really our only vision restoring treatment option for cataracts across species. When we consider congenital cataracts, one of the big decisions to be made is the best time to evaluate the horse and perform the surgery. And that's mainly broken down into, do we do it pre-weaning or post-weaning? There are certainly positives and negatives to either. For foals that are born with advanced cataracts in both of their eyes and are, truly blind from the disease, early surgery when they're still with their mare likely allows for them to have kind of a more normal behavioral development, and it minimizes stress as opposed to putting them through the stress of the separation of weaning when they also cannot see. That said, younger foals spend a lot more time down sleeping. They spend obviously a lot of time under the mare nursing, and being down as well as being under the mare can potentially predispose to some complications like infection, corneal edema, or even trauma. And then another big thing to consider is that in order for the central visual pathway, everything involved in vision behind the eye, behind the retina, the optic nerves, chiasm, tracts, the visual cortex of the brain, in order for those pathways to develop normally, they need visual input or stimuli. So that comes from light, seeing form, seeing motion, seeing color. And this must be received by the retina for these pathways to develop normally. And cataracts, when they're advanced, preclude essentially all of these from reaching the retina except for light. And so there's a pretty strong argument that can be made for early surgery to allow for better development of the central visual pathways, get the stimulus there earlier, allow them to see earlier. However, you just have to weigh that with the potential for both the ocular and potentially systemic complications that can arise when you intervene with a young foal versus an older weanling. So, after discussing kind of all of that with the owner and their primary veterinarian, we kind of made the group decision that they did want to proceed with surgery prior to weaning. And so, or at least, proceed with evaluating the foal to see if it was a good candidate for surgery prior to weaning. And so he first presented to our team alongside his mare when he was about 4 weeks old.
So how did you come to the decision of when to pursue surgery for that foal?
Yeah, it's a great question. And really the decision's made on kind of a case-by-case basis. I think as long as the owners are fully informed and aware of all of the potential complications and the, positives and negatives of pre-weaning versus post-weaning surgery, really either is appropriate. And so it's kind of a client-led thing as long as there's no specific patient reasons to, wait or to cut them early.
So then how did you proceed from there once the foal presented to you all?
Yeah, so the foal presented to the hospital here at Cornell. As with all, patients coming into the clinic, we start with our basic thorough physical exam on the foal and the mare, which both were unremarkable. Then moved on to a complete ophthalmic examination on the foal. So this includes a neuro-ophthalmic exam, so checking menace responses, dazzle reflexes, pupillary light reflexes, palpebral reflexes. All of those were normal in this foal, except for he lacked a menace response on the left side, which was the affected eye with the advanced cataract. So that kind of fit with, the problem that we knew he had. Based on the fact that he did maintain light perception, so had a good, strong PLR, a good dazzle reflex, that is, suggestive that he would be a good candidate for surgery, but proceeded with a really detailed exam of both eyes. So using slit lamp biomicroscopy, the handheld microscope to see the fine details of all of the ocular structures, examined the back of the eye with indirect ophthalmoscopy. The cataract on the left side precluded us from seeing to the back of that eye. And so we'll talk a bit more about diagnostics pre-surgery. Measured intraocular pressures, fluorescein stain, tear production, the full complete exam. And findings were that the right eye, fortunately, was completely normal, and the left eye had an advanced cataract. We classified this cataract as hypermature, meaning that it not only occupied all of the lens volume, but it was also starting to resorb a little bit, so to liquefy a bit. So a really advanced stage of cataract. One of the really important things when assessing animals with cataracts is to dilate the pupil to ensure that you get a full view of the lens. So for the left eye, in this case, that was the eye that had the cataract, we wanted to be able to make sure we could fully assess the stage of the cataract, assess that lens capsule and its health. And then for the right eye, the unaffected eye, we wanted to make sure that there truly was no cataract that could have been kind of hiding behind the iris before the pupil had been dilated. And so our kind of final exam findings for this colt were that his right eye was normal and his left eye had an advanced hypermature cataract. And because that cataract precluded us from seeing to the back of the eye, so we were unable to see his vitreous and his fundus, where we see his retina and his optic nerve in the affected eye, we needed to do a couple more diagnostics to kind of confirm whether or not he would be a candidate for cataract surgery. So our typical cataract workup involves an ocular ultrasound, which allows us to assess the structural integrity of the vitreous, check for a retinal detachment, make sure there's no evidence of a retinal detachment. We can also assess the lens pretty thoroughly with ultrasound. Fortunately, in his case, other than the cataract, we didn't see any abnormalities, so no evidence of a retinal detachment or any pathology within the vitreous. And then we also need to make sure that, so we use the ultrasound to make sure there's no evidence of a retinal detachment. Just because the retina is attached doesn't mean it's functioning normally. And so we also need to do a test to determine the functional health of the retina, and that's called an electroretinogram or ERG. And so we performed an ERG, which showed he had normal retinal function in the eye with the cataract as well. So good news, for him, the ultrasound, the ERG, and then his basic exam indicated that from an eye standpoint, he was a good candidate to undergo cataract surgery in that left eye. He also had full blood work, so a complete blood count, chemistry panel. We scanned his lungs just to make sure he was an appropriate anesthetic candidate, given that he was a relatively young foal, and everything checked out well there. And so the owner elected to go ahead and proceed with surgery on the affected eye the following day.
Calling all equine veterinarians. Are you tired of feeling like you're on an island when it comes to caring for your patients? Decra Veterinary Products is here to bridge that gap. They understand the challenges you face. That's why they offer a comprehensive line of high-quality products like Zycosan and Osphos, and empower you to offer your patients cutting-edge therapies like ProVet APC. They're not just a supplier, though. DECRA provides ongoing training and support to help you stay ahead of the curve and deliver the best possible care. Visit www.decra-us.com to discover how DECRA can be your partner in equine health.
The surgery that we perform for cataract surgery is called phacoemulsification. Commonly, it's referred to as phaco because that word is kind of a mouthful. And what this technique does is it uses ultrasound energy to break up or liquefy the cataractus lens while concurrently providing irrigation of sterile fluid into the eye and then aspirating out that fluid along with the particulate and liquefied cataract. This is a surgery that does require general anesthesia, and it also requires a neuromuscular paralytic to prevent movement of the globe during the surgery. And I'm super lucky to work with a really skilled anesthesia team here who take care of kind of all of that aspect of the procedure and allow us to focus on the surgery itself. Prior to cataract surgery, we do need to provide some medical therapy. So generally we place a subpalpebral lavage system or an SPL, and the eye is medicated with atropine in order to dilate the pupil. That does a couple of things. It allows for a full view of the lens during the procedure, which is obviously really important to perform a precise surgery. It also helps to combat some of the postoperative intraocular inflammation or uveitis, which we expect to happen following the surgery. And then we also treat with topical steroids and topical antibiotics to minimize inflammation and reduce the kind of bacterial load on the ocular surface prior to surgery. And then systemic pre-ops are kind of, typical intravenous antibiotics, and then flunixin is commonly utilized. The cataract surgery itself involves some small corneal incisions through which we can insert instruments to access and remove the cataract. Once we make those corneal incisions, we keep the anterior chamber inflated with a viscoelastic material, which is most often hyaluronic acid. And that helps to just keep the globe formed and allow us to see well in order to do a thorough job with the surgery. And then to access the cataract, we make a small incision in the anterior lens capsule. And then we actually have to turn that linear into a circle. So this step of the surgery is called the capsulorhexis. And it's a really important part of the surgery. You want to get it right because the lens capsule is really, really thin and it's really prone to tearing. So if you're able to create a perfect circle, that really minimizes your risk of having a complication of a capsular tear as you proceed through the surgery. So it's one of the kind of more challenging and delicate aspects of the surgery, but important to kind of get right there. Once you have access to the cataract, because you've made that tear, that circular tear in the anterior lens capsule, you can then proceed with the phacoemulsification, which is the technique we use to remove the majority of the lens. So once the most dense part of the lens, the dense part of the cataract has been removed, we can then switch to a different technique called irrigation aspiration. So this is putting fluid into the eye while subsequently aspirating it out, along with aspirating out any residual lens material without the need for that ultrasound energy from the phaco. And that just helps to minimize any, trauma inside of the eye, risk of capsular tears, that kind of thing. And then once we have the cataract completely removed, it's very much a kind of clinician preference, potentially in consultation with the owner, as to whether or not to place a synthetic intraocular lens or an IOL into the eye. If we do not place a lens and the eye is left what we call aphakic without a lens, what that means for vision is that light coming into the eye doesn't get bent as much. Essentially, the function of the lens is no longer there. So it can't bend light, and light entering the eye, therefore, does not converge right on the retina. And so vision is not normal. The animal will be very far-sighted. While we know that placement of an IOL or that synthetic intraocular lens allows for good, probably pretty much near normal vision for most horses. They can have additional complications from either the placement of the IOL itself or actually just from the IOL being present in the eye as kind of a foreign body. And we'll talk a little bit more about that shortly, as this colt did receive an IOL and had some complications associated with it. So essentially, to place that IOL, we do need to make one of our corneal incisions a bit larger. So we enlarge that incision, and then the IOL is inserted into that remaining lens capsule. It's kind of folded in half and grasped with specialized forceps, introduced into the capsule, and then a second instrument is inserted into the eye via a different incision to kind of manipulate that IOL so that it sits well in the lens capsule. Once the IOL is in place, we suture up our corneal incisions, and then, head to recovery. And fortunately, this colt had a very routine cataract surgery, routine phacoemulsification. Like I mentioned, he did receive an IOL. Everything went smoothly with its placement. The corneal incisions were apposed routinely, and he also had a routine smooth anesthesia and hand-assisted recovery, and kind of bounced right back to his stall to get back to his mare. Our post-op care for cataract surgery is really important. Generally, it consists of topical steroids and topical antibiotics via the SPL that was placed preoperatively, as well as continuation of systemic antibiotics and systemic flunixin. Some people use systemic steroids over NSAIDs, and I certainly do that as well on a case-by-case basis. Depends a little bit on the signalment and what's going on with the eye. Eye protection following surgery is another thing that's very much, a clinician preference. I certainly sleep better at night knowing that my patients are kind of wearing a well-fitted protective mask when they've undergone an invasive and expensive surgery like cataract surgery. So for me, cataract surgery would be an indication for a protective mask. Of course, in our babies, we need to be cognizant that they're going to be under the mare nursing, and so choosing a mask that is protective for them but comfortable for the mare is something to consider. So now we kind of get to the exciting part of this case and cataract surgery in general, which is talking about the complications that can occur following cataract surgery. And this colt had a couple complications, which we'll talk through. So corneal ulceration, which generally occurs around that corneal incision, the larger corneal incision typically, is a pretty common complication. And it's a frustrating one because it, certainly increases their risk of infection. We rely pretty heavily on topical steroids to address the postoperative inflammation that is expected with cataract surgery. And when they develop a corneal ulcer, generally we need to stop that topical steroid in order to prevent it from becoming infected and allow it to heal. And so then we have to rely more on our systemic anti-inflammatories to address that expected postoperative uveitis. So corneal ulceration, pretty common complication following surgery. We can also see elevated intraocular pressures. These can occur kind of short term after surgery within the first couple of days, but they can also be more sustained and a longer term problem, which we would call glaucoma. Fortunately, it's not a super common complication, but close monitoring of intraocular pressure is indicated, and then adding, pressure lowering medications as needed if pressures are found to be elevated. In horses that do receive IOLs or that synthetic lens to replace their natural lens, we can see fibrin formation around the IOL. It's pretty common to see that within the first few days following surgery, and it can vary pretty significantly in its severity. So it can be anything from a few small strands, which don't really need to be addressed, to a really kind of significant fibrin web that can kind of fill up the lens capsule in that front chamber of the eye. And that certainly is something that would need to be addressed. The way we treat that is with an intracameral or into the anterior chamber injection of tissue plasminogen activator, or TPA, which is generally very effective at clearing that fibrin quickly. We think that the lens is the driving factor for the fibrin in most cases, because horses that don't receive lenses are really uncommonly impacted with fibrin post-op, whereas those that receive them, it's almost kind of an expected complication that they'll get fibrin. And then another complication, which we'll spend a bit of time on, is the potential for a detachment of Descemet's membrane. And Descemet's membrane is the basement membrane of the corneal endothelium. So it's, towards the inside of that cornea, really deep in the cornea. And we tend to see these when they happen right around the corneal incision. When we oppose our corneal incisions, we are not placing our sutures full thickness. We don't want suture material going the whole way from the ocular surface into the eye and then back out. That would significantly increase risk of an intraocular infection. So our sutures aren't quite full thickness, and therefore we're not actually opposing that membrane when we close these incisions. And if you have a larger incision, like if you've placed an IOL and if you've had to push that IOL through the incision, which can be a pretty snug fit, that potentially predisposes to these Descemet's membrane detachments, which can happen post-operatively. So when we see a Descemet's membrane detachment, how we appreciate that clinically is essentially they lose function of their corneal endothelium and they get significant corneal edema. The corneal endothelium usually pumps fluid out of the cornea. When Descemet's has detached, it takes the endothelium with it, and so that endothelium can no longer function to pump fluid out of the cornea. We see fluid accumulating in the cornea, and that manifests as dense corneal edema, which again generally happens kind of right around the corneal incision. Other, thankfully, less common complications of cataract surgery include intraocular infection and retinal detachment. And these are unfortunate because both of those can, quickly blind the animal. So fortunately, they're not something we deal with super commonly. Getting back to the specifics about our case, so post-operatively, the colt did well. He was assessed as comfortable. He was holding his eye, almost fully open, which is pretty typical. Those corneal sutures can be a bit irritating, so a little bit of squinting, a little bit of discharge isn't unexpected. But for the most part, they should hold their eye pretty much open. And in very good news, he was assessed the evening after surgery as visual. So he had an intact menace response in the operated eye and everything was looking good. By 2 days post-op, he had developed a peri-incisional corneal ulcer, as well as just a very small amount of fibrin around the IOL, which did not necessitate a TPA injection at that time. So, always unfortunate to have complications, but they're pretty much expected in any horse following cataract surgery to have some minor complications. So we did stop his topical steroids due to the ulcer. We actually ended up transitioning him from the flunixin that he was initially on to an oral steroid, which he was maintained on from that point forward. Within the next 2 days or so, he unfortunately developed pretty advanced and progressive corneal edema surrounding that larger corneal incision through which the IOL had been inserted. And so this became concerning for a focal Descemet's membrane detachment. Many of these, when they're early and small, they'll reattach on their own. So generally, we kind of give them time to see if they're going to reattach on their own. And unfortunately, in his case, it didn't seem to be happening, and his edema was progressing, so getting larger and more severe. And then he actually ended up developing something called bullous keratopathy, and that's where the cornea becomes so swollen with fluid that it actually protrudes. And in his case, it was so severe that he became unable to blink over the corneal edema, so he was unable to close his eyelids over the protruding cornea. And so in order to address that, we performed something called a tarsorrhaphy. So he was sedated and we actually sutured his eyelids closed. And that did a couple of things. It prevented exposure of that severely edematous cornea. And it also provided some back pressure against that fluid accumulation to hopefully induce it to resolve. And now getting back to kind of decision making about when to operate on these foals, This was a younger foal that spent a lot of time down sleeping, healthy foal, but, as they do, spent a lot of time down sleeping. And almost every time I saw him, he was sleeping on his left side, which was the operated eye. And so I do wonder if him spending more time down on that side, just based on gravity, maybe not necessarily precipitated, but kind of complicated his Descemet's membrane detachment and led to him developing that bullous keratopathy. So just something else to kind of throw into the mix of considerations. But fortunately, this foal had a really good response to the tarsorrhaphy. It was left in place for 4 days, and it was kind of a nerve-wracking time. Those 4 days, I wanted to leave it in long enough for it to have an effect in helping to clear that corneal edema, resolve the bullous keratopathy. At the same time, his eye was sutured closed, and so I wasn't able to do the daily or twice daily thorough examinations to see what's going on inside of his eye. Is there more fibrin? What's his pressure doing? That kind of thing. Fortunately, everything, at the time of removal of the tarsorrhaphy, everything inside of his eye was still going well, really minimal inflammation, pressures were normal, and the bullous keratopathy had resolved, and the corneal ulcer had actually healed at that 4-day point when we had removed the tarsorrhaphy. So he didn't end up having some significant inflammation of his cornea associated with that bullous keratopathy event. That's not too surprising. Generally, they will, grow blood vessels into the area, have some white blood cells infiltrate the area, but that cleared up really nicely with kind of routine post-operative treatment. And fortunately, he didn't have any further short-term complications. So one thing that plays a huge role in the success of cataract surgery is the post-operative management and identifying and managing complications that are going to undoubtedly arise following this surgery. So I generally prep clients for about a 3-week stay in hospital, or also shorter stay in hospital, but then transfer to a local layup facility for about 2 to 3 weeks, just so that we can watch them really, really closely, pick up on any complications that arise, and make sure we treat them promptly. Given the complication that this colt had, he did end up staying in the hospital for kind of a full 3 weeks. And then at that point was doing really well. So was discharged back to the care of the owner. She was a very experienced horsewoman and had an excellent primary vet who had done additional follow-up exams on the colt. And so far, the story has a happy ending. So he's about a little over a year out from surgery at this point. His surgery was last spring, and I just got an update from the owner that he's looking great and continuing to do well and maintains vision in the operated eye. So despite, some big setbacks, he fortunately had a good outcome and is still visual at this standpoint.
Oh, that's great. Do you have any concerns or considerations for the foal and his vision going forward?
Yeah, it's a great question. Generally, our guidance is that, any horse that has had cataract surgery probably doesn't have perfect vision. They're always going to have some change to their cornea from the corneal incision. If we don't place that IOL, we know that their vision is not normal because they are missing that function of the lens to focus light right on their retina. And then even when we do place an IOL, if they have significant inflammation post-operatively, they can still have opacities that develop either of the lens itself or of the lens capsule that may impact vision long-term. And so our goals in cataract surgery are generally to restore vision. So personally, I don't, if there's an early cataract and a horse that still has vision and is functioning normally, that horse is not a good candidate for cataract surgery just because it has a cataract. The cataracts that we operate are the ones that are truly blinding, and our goals are to restore vision for the eye, even if we can't restore it to perfect vision, to give them some vision in the eye so that they can hopefully do their job, have a better quality of life, etc. In really young horses, so particularly these foals with congenital cataracts, when we do surgery early, one thing we know that can happen and may happen for most is that they can have an opacity develop of that lens capsule. And the reason that happens is because during this surgery, we do our best to remove every single cell of the lens. But the reality is we can't get every single cell. There's going to be some lens epithelial cells that are left behind that are attached to that lens capsule. And over time, over the span of this horse's life, those cells are going to proliferate, and they're not going to do so in a normal fashion because they don't have, the normal contact with the other lens cells around them because those cells have been removed. So when they proliferate abnormally, they generally are opaque instead of being clear, and that can lead to capsule opacity, which can impact vision longer term. So that's something that we always discuss with clients, especially when we're operating young horses, which are usually the best candidates for surgery, that they can have some opacity develop of their lens capsule that in the future can impact vision.
Wow. It seems like there's just so many considerations to think about with these cases. It's just such a complex case.
Yeah, these cases are certainly interesting, and they're all different. Even if, it's just another congenital cataract, there's a lot of things to take into consideration in terms of timing of surgery. The surgery itself is very, intricate and complicated. And then again, identifying and managing the post-op complications is what I consider the most important part of all of it. Another really important thing to think about with these cases is that some of these cataracts, these congenital cataracts, probably not all of them, but some of them, have a genetic basis. We know that there are a few breeds of horses that are prone to cataracts. They're overrepresented for congenital cataracts. This was a Morgan colt. We actually know that there are heritable cataracts within the Morgan breed. His cataract didn't quite fit with the typical heritable Morgan cataract, which is generally within the nucleus of the lens, generally affects both eyes. But it's very possible that this cataract was in fact genetic. And so advising the client, especially given that this is a, young intact horse, that he should not be used for breeding in the future. They should probably avoid, breeding the same sire and dam together that created this foal to hopefully avoid perpetuating this problem within the breed. We don't yet have any genetic tests for cataracts in horses, but a lot of research is being done to try and uncover the genetic mechanisms so that hopefully at some point we have some breed-specific genetic tests to prevent, the production of foals that are affected by this problem.
Well, thank you, Dr. Knickelbein, for coming on the podcast and sharing this case with us.
Absolutely. Thank you so much for having me.
To our listeners, thanks for tuning in, and thanks to our sponsor, DECRA.